Hello, everybody. Greetings from Pathkind, a group under Mankind, Heartcare Foundation of India. I'm Dr. K.K. Agarwal, President of Heartcare Foundation of India and Confederation of Medical Association of Asia and Oceania. We have gathered today for an important discussion from the horse's mouth. Everybody today wants to know about the vaccine. Ever since we have seen a vaccine war between various companies, people want to know the efficacy versus effectiveness. First of all, they want to know that if 100 people are given vaccine, how many of them will develop antibodies? The second question comes is that if they develop antibodies, how long they will last? And third, they want to know what will be the titer of the antibodies. And then next, they want to come to know specifically the doctors, if I take the vaccine, how will I come to know that I have got an antibody response? Can I get it tested? If I get it tested, which antibody should I go for? We have two vaccines, Covaxin and Covishield. Both will produce the same type of a clinical test or a different test. We know in Covishield there is only S protein, and in Covaxin there is both S protein as well as we have the nucleocapsid. People also want to know that if I get a Covaxin, which is a dead vaccine, will my RT-PCR be artificially positive, like we get RT-PCR positive in a dead virus? Now, these are some of the questions everybody is asking. Then people start asking about why government of India has said that anybody with any allergy will not get the vaccine. As on today, 10% of the population will be out because government of India says even if you are allergic to any drug or food, you will not be given vaccine. How does this vaccine differ and how does the vaccine antibodies differ? That will be a point of debate and discussion today. The program will be that we will listen to Dr. Ashok Ritan, and then we will interact and also take up questions and answer your queries. Just to formally introduce, he is well known. Everybody knows him by now. Professor Ashok Ritan is a senior microbiologist. Earlier, he was on the faculty of All India Institute of Medical Sciences. He is a temporary advisor to CRO. He is an advisor and mentor to R&D and quality division of Pathkind. He has been on the faculty, as already said, to All India Institute of Medical Sciences. He is a WHO lab director of CAREC and PAHO. With that, every time I interact with him, I learn a lot. He's very clear in his ideas and basics and concepts. Let's listen to him and then we will interact. Over to you, Ashokji.
Thank you, sir. And this is... So, good afternoon, sir, and good afternoon, everybody. Today, we will talk about COVID-19 vaccine, the facts. And I've restricted myself initially to the two vaccines that are available with us, though I have another presentation as a standby where all the four which have been available have been compared, looking at what attributes are there. Eradication of smallpox, near elimination of polio and neonatal tetanus, and reduction of measles have been possible, along with 20 additional vaccines that we use, have prevented 2 to 3 million deaths annually. And it's been considered that vaccines are considered the safest and most cost-effective intervention control of COVID-19 disease and to bring to an end this pandemic by providing individual protection and subsequently herd immunity. Now, we know that the virus is an RNA virus. It has single RNA strand, and the part which is immunogenic is one is nucleocapsid, which is hidden inside the virus. But the most important, what is related to protection is the spike protein. The spike protein is a trimeric spike protein, and up till now we've been thinking that we need to focus only on receptor binding domain. But at the end, I will provide you some more evidence to indicate that maybe all three parts are playing a role. But at this moment, let's start with that the spike protein is the one which binds to the ACE2 receptors. So spike protein is like the key which opens the lock of the cell, and it enters inside and then produces, and then it takes over the machinery of the human cell and causes disease in us. Now, if the virus was in fact informed to WHO by the 29th or 30th of December 2019, by the 10th of January, the whole genome of one virus was made available. And by the next day, 6 more genomes were available. Since the complete genome was available, it made it easy for the scientists, without having access to the virus, it made it easy for diagnostics to be established. And that's why RT-PCR was started by CDC as well as by Cox Institute for identifying, and they could identify that this varied from the previous viruses by about 60%, so it became SARS-CoV-2. Then LAMP and CRISPR, other tests could be developed, but also vaccines could be started even before you had the virus with you. And so people who had been working on DNA virus and DNA vaccines and on messenger viruses and vaccines, as well as on using the virus as a vector for transferring HIV or HCV, jumped into this at once. Of course, the trouble with HIV and HCV was we do not know what gives us immunity. So immune protection was not clear. Here, luckily, it was clear, and all vaccines have focused on spike protein. So we know that it is the spike protein which is important, and the spike protein is what messenger RNA has been used. In the DNA, they've taken the DNA of the gene that codes for the spike protein, and of course in whole cells, they've just killed the virus and to use the same. So all the vaccines have related and focused only on the spike protein. Because we know that the virus, because it binds to the ACE2 receptors and enters, it will cause cytopathogenic effect. And protection will be provided if we can neutralize this cytopathogenic effect, then it will be protective. So it's easy to measure whether protective antibodies are made available and whether the vaccine is working or not. That is by plaque reduction neutralization test. On the right side, you find that the plaque is being formed. On the left side, antibodies in the blood have been able to neutralize this. We also knew by animal experiments that when a person recovers, he is relatively not he cannot be reinfected at once. So he has relative immunity once a person has once the animal recovers. it was also clear that Syrian hamsters who were the animal model for this virus, if only antibodies are transferred to Syrian hamster virus, then the Syrian hamsters who have had antibody infused into them, they are protected and they would not die. Now, there are a number of vaccines, about 215 vaccines in various stages of development. And in India, too, there are about 9 vaccines which are in various stages, and 2 have been given emergency authorization. So we concentrate on these 2. Each one of them, as I said, is focusing on the spike protein. The spike protein is the one which binds to the ACE2 receptors. I would compare the adenovirus, that is the Oxford strain, where they've used an adenovirus of the chimpanzee. The advantage of using chimpanzee adenovirus is that we will not have antibodies to adenovirus, and so we will not neutralize it. That means the take would be good. In the Sputnik vaccine, they've used human adenovirus. So there is some chance that that people might have antibodies to the adenovirus as it is. But adenovirus will help the DNA, which is encapsulated inside the adenovirus, to gain entry. If DNA is not required and we have done messenger RNA is very labile, so it will be destroyed in seconds. That is why, to make it safer, they've used lipid nanoparticles, and these are surrounding the messenger RNA. This will help both the DNA, the adenovirus, or the messenger RNA encapsulated in the lipid nanoparticles will gain entry into the cell. And once it gains entry into the cell, the messenger RNA or the DNA encapsulated inside the adenovirus will convert it into messenger RNA, and then it will instruct the machinery of the cell to produce a lot of spike proteins. And these spike proteins will then act as long as the messenger RNA or the DNA remains, it will act as a factory for producing the spike protein. And these spike proteins, when the cell dies, will be taken up by the antigen presenting cells and presented to the B lymphocytes and T lymphocytes, and they will produce copious amount of antibodies which will neutralize the virus and kill infected cells. And this is how protection would occur. Now, the 2 vaccines which have been, 2 have been approved, and 3 are on the way of approval. One is Cadilla's DNA vaccine. Sputnik has now gone into phase 3, and Biology E is also doing a recombinant protein vaccine, which might be coming soon. There are others also in the way. In Covishield, 1 dose of the virus will be 0.5 ml, and this has to be given as deep intramuscular in deltoid region, and 1 dose consists of 5 into 10 to the power 10 viral particles. We would have heard that in UK, some of them had got half the dose, but the regulatory authorities have insisted that the full 5 into 10 to the power 10 viral particles must be there in every dose. So only standard dose is permitted. This is a recombinant replication deficient chimpanzee adenovirus. It encodes SARS-CoV-2 spike glycoprotein, and this is produced in human embryonic kidney 293 cells, and the solution is colorless to slightly brown, to clear to slightly opaque. It is particulate free. pH will be 6.6, and this is not to be shaken before use. And 2 doses would complete the schedule. There is some evidence that the longer the period between 2 doses, the more protection would occur. But it's also obvious that protection is best after 7 to 14 days of second dose. So there's a confusion between whether the limited amount of vaccines should be given, 1 dose should be given to all, or 2 doses should be given to limited persons. And it's been suggested that if you have taken Covishield first time, then the second dose should also be Covishield. At this moment, there is no data available on switching of vaccines or mixing up the vaccines. There is no dosage adjustment required in the elderly. It has not yet been approved for anybody below 18 years of age. The contraindications, as Dr. Agarwal indicated, is hypersensitivity. If a person has severe allergic reaction, then it is contraindicated. But if it is mild allergy, then I think the benefit far overweighs the risk involved. If a person has minor cold or cough or something, they can still have the vaccine. If it is severe illness, acute illness, then it's best to avoid. There is no data available at the moment about immunocompromised patients or those who are going to undergo immunocompromised treatment. But persons who have thrombocytopenia or who have coagulation disorders, in that case, bleeding might occur or blobs might form. So precautions should be taken, but it should be given. And duration of protection, at the moment, it is not established. The persons have been followed up for at least 2 months, but it appears at least that the protection will last for 6 months or so. As I indicated, that interchangeability of the vaccines, of the 4 vaccines, there is no data available, and it's not suggested that persons should shift from one vaccine to another vaccine. There's no data available to indicate whether there's any effect on fertility, pregnancy, or lactation, and ability to drive or to use machines after vaccinations. There is no contraindication to that. It is agreed that ideally, during the development of vaccination, we would follow up a person for 12 months. But this is anything but ordinary times, and therefore people have been followed up for 2 months, and I think there's sufficient body of data available to indicate that the vaccines are effective. They have given, this has been summarized for Covishield or the Oxford vaccine. There were 4 trials which have been summarized. 23,745 participants over 18 years were randomized, and 12,000 persons have received at least 1 dose. And they find that as far as safety concern is there, most of the persons suffer from tenderness and pain at the site of injection. There is a few who have headache, there's myalgia, some of them have had even fever, but that is why they have normally suggested that paracetamol can be given to take care of this mild symptoms that appear. Normally, all the symptoms subside within a few days, and the second dose seems to be more tolerated than the first dose, and adverse reactions are milder and reported less frequently in older persons than in younger persons. Again, in Covishield, there's been no real cause for concern. as you know, that when you take 40,000 persons, you would find some adverse effect or the other, and they are normally blinded during the study. It's only after the blind has been removed, then you can say whether it's been associated, whether the adverse effect has been associated with the vaccine, or it's a spontaneous occurrence. The mechanism of action, as I mentioned, was that it has the DNA of SARS-CoV-2, which the chimpanzee adenovirus will introduce into the cell, and the cell will produce spike protein, and spike protein will stimulate neutralizing antibodies as well as cell-mediated immunity. In clinical efficacy, the best is to follow for 12 months. And of course, during the enrollment, they made sure that persons who had anaphylaxis or angioedema, allergic reactions were excluded. Severe CVS, GIT, liver, renal, metabolic and neurological diseases were also excluded. 2 doses were given, and for logistics reasons, sometimes it was the difference between these varied from 4 weeks to 26 weeks. And one group in UK was administered half the standard dose, but that the regulators have tried to ignore. In the efficacy, they find that if you look at efficacy, that would mean to prevent COVID infection, then persons in the controls, there were 101 infections, while in controls, while those who had 2 doses, there were 30. So they indicate that the efficacy is 70%. If it comes down to after 1 dose itself, then there were 108 in those who had at least 1 dose. And in the control, it was 227. That would mean the efficacy at that time was 52. So ideally, it is there that you should complete 2 doses of the vaccine, and it's only after 14 days of the second dose that you should feel that you are protected. When they look at the antibody titers, then you find that after the first dose, 20 days after the first dose, the titer was 8,000. As you see here, if the difference between the first dose and the second dose, as the distance increased, the antibody titer seemed to increase. And as much as 63,000 antibody titer was present if the difference between them is 12 weeks. But it's not recommended to exceed 4 weeks. So the first dose and the second dose should be taken after 4 weeks. We noticed that this was the report from China, that not everybody responded after they recovered from illness. Those who had mild illness, they had antibody titer which was low. Antibody titer, neutralizing antibody titer was high in those who had critical illness and severe illness. When we had analyzed our results, we find that the titers against NCP, total antibody was little. And then when we look at anti-spike, only 2 persons had more than 1,000 antibody titer. And as I've indicated, that 1 dose, 28 days after 1 dose of Oxford strain will lead to about 8,000 as the antibody titer. And the second dose will make it 20,000, etc. So the vaccine is highly immunogenic, much better than after having recovered from an infection of COVID infection. Now we shift over to Covaxin. Covaxin is a killed vaccine, whole cell killed vaccine. 1 dose will consist of 0.5 milligrams ml to be given IM. again in the deltoid region, and each vial is multi-dose vial containing 20 doses. This has a shelf life of 6 months. It should be stored between 2 to 8 degrees Celsius. The solution is white, translucent. It should be shaken well before use. Oxford's vaccine is not to be shaken. Covaxin is to be shaken well before use. This is freeze sensitive. It should be discarded if it is frozen or if there's particulate matter present. The dosing is 0.5 ml to be given IM, preferably in the deltoid, and 4 weeks apart. And complete vaccination should be done with the same vaccine that you use for the first dose. There is no public data available over Covaxin except for 2 papers which are in preprint. That means they have not been peer reviewed, and they are available on the website of ICMR. And I have then taken the liberty of taking their paper, the 2 papers which are both in preprint at the moment. In this, when you look at Covaxin had taken 4 arms, 3 were vaccine arms and 1 was control arm. They used 3 micrograms of the killed virus along with agar gel and adjuvant known as IMDG. And they used 3 micrograms, 6 micrograms, 6 micrograms only of agar gel or aluminium and alum as an adjuvant, and they gave 2 doses and 14 days apart. Then they looked at reactogenicity, safety, and immunogenicity, and the results were that the reactions was mild, absent in majority, quickly resolved, less in the second dose, and robust immune response comparable to convalescent plasma was found. No significant difference between 3 and 6 micrograms with alum and IMDH, and no neutralizing antibodies were detected, and CMI was of Th1 phenotype, which indicated that it would be of the helpful type. And the second paper that they have submitted for publication, not yet published and not yet peer reviewed, was that they looked at seroconversion, and they found that 6 microgram with IMDG gave best result of 81% of seroconversion on day 104, and the neutralizing antibodies were very good on day 56 in 92 to 98% of patients, and this was of Th1 response. And when you look at seroconversion occurred in majority of persons, and that's why 6 micrograms alum IMDG adsorbed was selected for phase 3 efficacy trial, which is still undergoing at the moment. Overall, as you look at the ELISA antibodies, and you find that on day 28, there was good amount of antibody, 2,574, which is much higher than the best that we got for convalescent plasma, which increased to 11,528 on day 42, and increased to came down slightly to 10,000 by day 56. Even RBD, as you notice, from 500 originally, it went up to 1,962 and then 5,500 on day 52. And after that, 5,874 on day 56. So you find that there's robust immune response to Covaxin. When you look at the wild type neutralizing antibodies, then by day 42 and 56, good amount of neutralizing antibody can be seen. and when you compare with asymptomatic sense convalescent plasma. And again here, this is the plaque reduction neutralization test, which indicates whether neutralizing antibodies are present. And as you see, the difference is clear-cut on 28 days, 42 days, and 56. And with this, you would expect that there'll be good efficacy in real life too. As I'm mentioning that they claim that there's good CMI also, and they looked at Th1 and Th2 response. For Th1 response, they monitored in interferon gamma, TNF alpha, and IL-2, and they find that the pro-inflammatory Th1 cytokines were much higher than IL-5, IL-10, and IL-13, which are anti-inflammatory or for pro-allergy cytokines. So this is Th2 response. So in this case, because of alum IMDG, they feel that they get excellent Th1 response. Combined together, they feel that with 6 micrograms, there is good amount of neutralizing response, which is better than human class convalescent plasma. There's recently a paper, of course, as you might remember, that ICMR had submitted to BMJ a paper indicating that convalescent plasma, if it is given, it doesn't make a difference. But recently from Brazil, there was another paper which indicated that early high titer plasma therapy to elderly persons would be very beneficial. And this indicated that 250 ml of high titer, that means more than 1,000 more than 1,000 arbitrary units of anti-spike should be there in the plasma, which it is, if it is transfused in persons before 72 hours then it will be beneficial to elderly persons. And from what I have been presenting, it appears that convalescent plasma may not work in India, but persons who have responded to the vaccine may be in a better position because they'll have much higher titer, and their plasma may be useful in giving this high titer plasma to persons who are sick, who are admitted, but it needs to be done early in course of their illness. Recently, it's also been there. Then, because antibodies are working, people started making monoclonal antibodies. And looking at various monoclonal antibodies, they found that neutralizing monoclonal antibodies reacted not only against the receptor binding domain, but also the end part of the spike protein. And if there were 9 monoclonal antibodies against the RBD, there would be 8 antibodies which will act against the end side of the domain. And this, then when they tested one after the other, they found that they are good. These that monoclonal antibodies are good, but they react against various epitopes. There's not only 1 or 2 epitopes, there are multicentric epitopes. And Disorin has recently introduced a trimeric antibody test, which looks at all the 3 parts of the spike protein and would detect whether neutralizing antibodies have been produced are already present or have now been produced as a consequence of the vaccine that a person takes. And we can offer this to anybody who's interested. Now we can take question and answer, sir. So that's all I had.
So, Ashokji, can I take the slide off?
Yes, sir.
Ritu? So I'll come back to some basic discussions, and then we will also take questions from the people who are watching this program. So we have a large number of questions who have come. But before that, let me go back to some basics. The first thing you said that when the first genome was produced, there was 1+6 genomes were given in 2019 December. What does those means?
No, sir, in January 2020.
Can take the slides out so that can.
Ashok, so please click on stop share.
Stop share.
Yeah. Okay.
Yes.
Yeah.
So my first thing is when we said that the scientists had 1+6 genomes. What is that?
The whole genome of using next generation sequencing, they could share with everybody the whole genome of the virus. And that means that even though you did not have the virus with you, you could then design
You could replicate a virus in your lab.
Or the virus, yes. Okay. You have the virus with you, or in a way you can start working on the virus, find out what, because it was already decided that it's the spike protein which is working, so they can then design out.
How are they sure, or how are we sure that it is only the spike protein which is pathognomonic? Why not the non-structural proteins? Why not the E membrane or the membrane or the envelope, that they do not cause any disease?
So I think partly it was because of the work that had gone on with SARS when it came in 2003. In 2003 also, SARS would bind to ACE2 receptors, and they were getting the vaccine. They were working on the vaccine. They had already decided that this is how it will be done. And SARS on its own, it switched off. So everybody lost interest in the vaccine. Even
what I'm trying to say, the virus has many parts. Let's take non-S protein part of the virus. I'm talking about non-S protein part of the virus. Does that part also causes some antigenicity or some clinical features in the body? Is there any study?
No, for example, they said the nucleocapsid protein, though it is more immunogenic than spike protein, but the nucleocapsid protein in nature will be hidden. So it will not have neutralizing activity. It might have, subsequently, it might help in clearing of the virus, because once the nucleocapsid is bound, antibodies are bound to nucleocapsid.
Now, why I'm asking this question is, suppose I give you option of 3. One is a live attenuated vaccine, which is a full virus, live but attenuated, which has both the nucleocapsid and all the 3 portions of the spike protein. 2, killed vaccine, which is whole but killed. 3rd is only spike protein. All 3 will be different. So the live vaccine will produce the maximum antibodies. It will produce antibodies against every part of the virus. So therefore, let's assume now the kill vaccine is producing antibodies against the envelope, against the membrane, against the nuclear capsid, and against all the 3 portions of the spike, and RBD and RBM. Yes. So this will be polyclonal response. It will not be a monoclonal response.
Yes, sir.
In a Covishield, it will be a type of a monoclonal response only against the S protein. And we don't know whether they are using all the 3 portions of the S protein or not. We don't know, because as of today, we have not seen their response, which portion of the S protein they have used. So will it make a difference theoretically?
It will be, suppose it is using only a small portion, then, and when mutation occurs, then the receptor binding might cause problem. But if it is polyclonal, but it is interfering in receptor binding, it's interfering in, because once we understand the mechanism, we know that the virus will bind to ACE2 receptor. And if you prevent this binding, then the virus cannot enter. And actually, it's been seen that if there's N501D mutation instead of N501Y mutation, then N501D is the bat virus, which has no affinity for ACE2 receptors. So it is avirulent. While N501Y has increased transmissibility by 70%. So it is just one mutation, which and a number of mutations can be then produced, and then they try to model to see what will help, what will work, or what will not work. So that because the gene sequence was known, so persons who had no access to the virus could still start working. And I think that is what
484 is another mutation which is of concern, because it takes care of the 484 is noticed in Bombay also. It is seen in South Africa and Brazil, which they say is a RBM, which is a receptor binding moiety. And there is a mutation, and it takes care of the monoclonal antibodies don't work. So what are the different types of monoclonal antibodies? Class 1, class 2, class 3. How do we, as a common doctor, how do we understand different types of neutralizing antibodies, NABs?
So neutralizing antibodies would be, as this paper from Liu had indicated, that instead of only receptor binding, the monoclonal antibodies normally antibodies have only 5 or 6 amino acids at the epitope. So one monoclonal antibody will bind to 5 or 6 amino acids only. So since the spike protein has about 1072 amino acids, so there could be copious amount of antibodies, monoclonal antibodies, which could be produced. Now, among them, there will be only certain sites in the receptor binding domain which binds to the ACE2 receptor. So if that is blocked, or if that is modified, then that might increase the fusion. So after it is bound, then the membranes will fuse, and then the RNA of the virus will be able to enter into the cytoplasm.
So I come back to the basic question which everybody wants to know. And that is what you elaborated is post-vaccine convalescent, I won't call them as convalescent, post-vaccine titer as a donor. Can a post-vaccine person donate his serum? Has it been done anywhere? Will it implicate anything? Has it happened in any other disease where post-vaccination you donate your serum? In any other disease? Because you are seeing your titer is going to be very, very, very high, though you have shown that in Covishield, the titers are much higher than in Covaxin, the titers. So in that particular situation, we are assuming that a post-COVID person can donate convalescent plasma, not convalescent, post-vaccine plasma.
Post-vaccine. So that should work, because again, because what is happening is in convalescent also, when
in convalescent it is polyclonal. It is S protein plus N protein. It is against N antibodies also.
But because it is giving protection, polyclonal actually means polyclonal. Normally,
not polyclonal, but multiple antibodies, poly antibodies, you can say.
Multiple site of antibodies, while Covishield will be only against the spike protein.
So have we got any evidence in the past by any vaccine where the serum has been used to treat patients after vaccination? Because that is something which can be a game changer in the society to treat serious patients. This is what I'm trying to say.
I still have to look at the literature, whether it's been used, but I think we've not had this kind of scenario earlier. where natural immunity, natural recovery, when a person has mild infection, very little antibodies are produced. When a person has severe infection, there also the recovery is less than 500 arbitrarily unit. But one dose of Covishield and you have in thousands. So obviously it would mean, and of course it in Brazil, as they seem to have responded more because they had I think 60 persons in their group, and when they no 80% in the group, they gave to 40, and they decreased the complication by 50%. So they seem to have high titers, and they gave 250 ml of plasma to within 72 hours. But I would suggest that if the titers are as high as indicated by Covishield, then these persons would be good donors because they will be relatively healthy. Persons who have recovered from COVID were less likely of those who have severe infection are less likely to donate blood because they've recovered.
So what are the chances of developing non-neutralizing antibodies?
Non-neutralizing antibodies would also be there, but that is more likely with Covaxin because it is whole cell, and person will respond not only because there is no selection of the spike protein. Even in Oxford strain, there were antibodies developed against the adenovirus. And that is why I think Sputnik has been talking to them to see
the second dose.
They can the second dose could be a different virus, so that it doesn't then the virus is not neutralized by the human beings by producing.
So I'm only going to say is that if non-neutralizing antibodies are formed, won't they precipitate a Th1 response with any other infection, non-specific?
No, then they would not recognize that as an antigen, or antibodies will be formed, but they would recognize only their homologous antigen that has produced it. So if it is not shared, if the antigens are not shared on any of human cells, then there'll be no reaction, sir.
So is vaccine, Rizwan Khan is asking, is there any difference in safety between the two vaccines?
Safety-wise, there, sir, not with Oxford, but yes, with both Pfizer and Moderna. What has happened is, since they use nanolipid particles, there is polyethylene glycol also present, and polyethylene glycol is a normal preservative used in many of the medicines. So if we have antibodies to polyethylene glycol, then it is likely that we might have allergic reaction. And we know that against the Pfizer vaccine, about 6 to 8 anaphylactic reactions have occurred.
So Preeti Gupta is asking a question that I am a doctor. I suppose I get this vaccine. And if I want to know whether I am a vaccine failure or not, how will I come to know that I have not responded to the vaccine?
By finding out the neutralizing antibodies, those are available, commercially available now.
So before that, she should go for a simple S antibodies?
Yes, sir. Spike protein antibodies would indicate whether they are already present, and if after the dose, if it's not risen, then naturally it means that she is not responding. But in the thousands of persons that they have reported, none of the papers indicated that a person did not respond. Unlike, as you know, with hepatitis B surface antigen, about 5 persons never respond.
No, do you feel that with this vaccine, everybody will produce some antibodies?
At the moment, maybe they have already selected out or not selected in those persons who might not have responded, because there's been nobody who has been immunosuppressed, anybody who had
No. If you give vaccine to 100 people, 100% people are not going to get protected.
Not protected. They would respond at various levels. Yes, there would be a difference of titer. That is true, and some will reach the level, and that is why they say that the second dose. What had happened, sir, that after 28 days, they found that the titers were good, but after 28 days, it started falling. That is the time when they felt that second dose is required. But there was a delay in getting the second dose available.
So I can say that everybody who gets the vaccine will have some response. Therefore, it is likely that if they develop COVID, it will not be severe.
Yes, that is likely to be there.
So there will be, everybody will have some response, some protection.
So in this, it is explained in the sense that when you give the dose, antibodies are of IgG type, while for local protection you need IgA, and so it is possible that because we have IgG, individuals who have been vaccinated would not have any serious systemic infection.
So why the IgA antibodies are not formed?
So because that this antigen is in the muscle, and then the antigen will have to travel to the mucous membranes for the IgA to be.
And why not IgM antibodies are not produced?
In the muscle, it seems to be that normally IgG is the one that is produced in vaccine.
So is the vaccine safe? And there are so many conditions people are asking. And somebody wants to know more about the diazorin trimeric test.
Diazorin at the moment was using S1, S2. So S1, S2 would look at only protective antigen. But as the Lee's paper indicate that it is not only S1 and S2, but also the third part domain, which is at the top of the spike protein. All three needs to be tested, and monoclonal antibodies have been raised against all three domains, and they find that you would then be able to have a better idea about neutralizing antibodies.
So you are saying that diazonic now has three parts, all the three parts of the spike protein, it is including into detection of antibody.
Detection, yes, sir. So they'll detect more.
So is that test available?
Yes, sir. They have launched it day before yesterday. They have launched the Trimeric.
Trimeric. How much does it cost?
I think the cost is always on the number of samples that come, because
how is it commercially available?
Yes, it's commercially available, sir.
And it is available with PathKind.
Yes, sir.
Okay. So Preeti Gupta is again asking, please discuss for second dose of different vector vaccine to prevent failure due to antibodies formed again. No, at the moment, Preeti ji, it is not allowed. The government has not allowed interchanging of vaccines. So you cannot take, as on today, a Covishield and then follow it by Sputnik. As on today, it is not allowed. Before, and this is Vajyapal Ravinder Rao, before COVID positive, same days treatment offer negative. I'm not been able to understand. Before COVID positive, I'm not able to understand your question. Will this vaccine, like we have will this vaccine also help in preventing other diseases with a non-specific immunity? Like we say, BCG gives us non-specific immunity. So will this high titer also prevent other diseases from this vaccine?
There's no data available, sir. It's difficult to project those things.
What is the difference between the Sinopharm China vaccine and Covaxin of India? Both of them are inactivated vaccines.
I have not looked at Sinovac, but I think for Covaxin, they are using the killed virus, yes, as Sinopharm will be, but they're using it, they're absorbing it with alum and that adjuvant, which they've got as uh,
IMDH.
DG. IMDG is the adjuvant that they've got, and that seems to be a good adjuvant. And so the adjuvant, the antigen may be the same, but the adjuvant is the one which will convert haplotype into a real antigen.
So people who wants to remember, because even we forget about, we get confused about the word IMDG. So remember the word IMDG, the Director General. I am the Director General of India, who is ordering you to take this vaccine. So you can easily remember IMDG. So that's IM means I am KK Agarwal. I say IMDG. That's where you can remember this, because for me also I was getting it, I was forgetting it again and again. It's an easy way to trick to remember. How does this adjuvant work?
So the adjuvant is that means it presents better to the antigen presenting cells. What happens is that if the antigen is too small, and then it's a hapten, but an adjuvant will make it as a complete antigen, and then copious amount of antibodies will be produced.
So basically, it helps the antigen presenting cell identify the antigen, something like the work of a dendritic cell.
Yes.
Okay. So normally what happens is when a virus comes inside my body, inside the cell, based on the major histocompatibility complexes, it identifies what type of a protein is being projected. And if the protein size is very, very, very small, then dendritic cells or NK3 cells, that is dendritic cells takes over, or this NK natural killer cells takes over. And that natural killer cell, which is CD3, they identify smaller portions. So I would remember it like that. Adjuvant works like a natural killer cells, so that they can identify, or the dendritic cells, they can identify smaller particles of the protein with that. So if let me see if any other question is there. I don't find any other. So for all, the vaccine is here. The government of India has declared this is pregnancy no, breastfeeding no, allergic no for the time being. Whether you are allergic to a drug or an injection or a food, currently it is no. You are HIV positive, yes. You are immunocompromised, yes. You are on immunosuppression drugs, yes. You are comorbid, yes. These directions have come. No interchangeability of the vaccine will be allowed. Anybody above the age of 18, vaccines will be allowed. At the moment, government is concentrating on giving 3 crore vaccines. Their aim is by July, approximately 30 crore to be given vaccine. If I have already developed an antibodies, no contraindication. If I have already developed COVID-19 disease, I was RT-PCR positive, no contraindication. They have not given any instructions on the current illness. Pregnancy, they said no. Breastfeeding, they have said no. And they also said if you are suspecting pregnancy, then no. But there is no clarification that if I become pregnant after the first vaccine, should I take the second one or not? That type of information will come. In the ministry, they have given clear-cut writing that kindly watch for demyelinating diseases. They are not linked, but observed. So they have not proven to be linked, but they are observed. That's all for today. Let me thank Professor Ashok Ratan to be here and make you understand about the vaccines. This program is available on YouTube. It's not easy to understand virology, vaccinology. It's not easy. So therefore, you may have to see these slides again and again. We will be back one of these days with another topic. We know that one topic we have promised you where we want to come back is of a highly clinical importance, that's interpretation of CT value, which I will request Dr. Ashok Ratan to talk to PathKind, and because that is one subject which will attract everybody's, everybody wants to know, how do I follow CT value?
Next.
We'll be back. Yes, we will be back with one of these seminars.